Our case study is on Guillain Barre, and it's by Megan, Allison, Bree, Annie, and Cooper. So what is Guillain Barre? Its official name is acute demyelinating polyneuropathy. It's an autoimmune disease causing acute inflammation and demyelination of the peripheral nervous system sensory and motor fibers. It's characterized by flaccid paralysis, absent reflexes, and elevated levels of protein in normal cells and cerebrospinal fluid.
So the most commonly affected people by Guillain Barre are those of the male gender and young adults. However, it can occur at any different age, and it's usually triggered by an infection. One of the things below, Campylobacter, which is a bacteria found in undercooked poultry. It can be caused by the flu virus, the Zika virus, hepatitis A, B, C, and E, surgery, and others, including the more recent COVID-19. There has been at least one case of Guillain Barre related to COVID. And like I said, Guillain Barre is typically triggered by an event that causes an immune response, which then induces an abnormal autoimmune response. Mild infection is commonly the triggering event, and in the process of fighting off the infection, the person's immune system is overactive, and it creates antibodies that then attack Schwann cells. A different type of Guillain Barre may occur based on the event that triggers Guillain Barre. For example, C. jejuni infections tend to affect the motor axon, causing more severe weakness and a poor outcome. This is a type of acute motor axonal neuropathy.
So a bit more about the types of Guillain Barre. This is based on the part of the peripheral nerve that is damaged. You'll see that in the names here. So there are types that degrade myelin, which are acute inflammatory demyelinated polyneuropathy and acute sensory ascending neuropathy. Some damage the axon itself, such as acute motor axonal neuropathy and acute motor sensory axonal neuropathy. And when cranial nerves are involved, that's called Miller-Fisher syndrome. Antibodies are triggered to attack the peripheral nervous system, as we talked about earlier. And there have been some different antigens that have been found in patients with Guillain Barre. The antigens are triggered by the infection and then attack the Schwann cells. And here are some of the antigens that have been identified listed here.
So a little bit about the neuroanatomy and neurophysiology of Guillain Barre. As we know, Guillain Barre attacks Schwann cells, which are the myelin-building cells of the peripheral nervous system. Any of these can be affected: peripheral nerves, which are sensory and motor, spinal nerve roots, cranial nerves, and the preganglionic fibers of the autonomic nervous system. This means that a range of symptoms are possible, from motor loss to the inability to breathe. We see this all the time clinically with patients with Guillain Barre, as they can go from just having motor weakness to being put on a ventilator and having no motor input at all. And then we, of course, see some recovery with that. The ANS involvement could cause tachycardia, cardiac arrhythmias, changes in BP, and vasomotor symptoms. Recovery, clinically, the first thing that is done is treatment with the use of IV immunoglobulin or plasma exchange, and it's started right away before the damage cannot be reversed. Inside the body, the repair begins after the demyelination of Schwann cells. The myelin is repaired, but the area between the nodes of Ranvier will be shorter than before, decreasing conduction speeds. What this means for us is that while we can see recovery, a complete recovery, as in they're exactly the same before they had this disorder, is not likely to not possible. Some degree of axonal degeneration occurs in each type, and this damage is longer lasting. So a couple stats about the recovery. After 1 year, 67% see full recovery, but 20% have severe lasting impairments. Even after 2 years, 8% still haven't recovered. Relapses occur in up to 10% of cases, and 3 to 7% mortality rate in Europe and North America. What this tells us is that we do have a chance of seeing severe lasting impairments, but we have a greater chance of seeing a full recovery to at least a partial recovery in patients with Guillain-Barre.
So the patients typically present with an onset to peak impairment in about 4 weeks. And typically there are more motor than sensory losses. So this includes symmetric motor weaknesses and distal sensory impairments. There's also decreased or absent reflexes. And about 50% have palatal and facial muscle weakness, and then up to 30% require ventilation, which was mentioned earlier. Some will also have pitting edema. So here are just some scales that if the patient that we have presents with edema, that you can go off of to measure that. And then things for the PT to keep in mind. So Guillain-Barre is quite complex. So you will have to watch for changes in vital signs before and during treatment. So blood pressure and heart rate tend to change with positioning. So as we've learned before, that's known as orthostatic hypotension. They may have difficulty breathing as you move them, and then their oxygen saturation tends to be very low, like in the low 90s. So as you transfer them, just make sure that you're constantly asking them about their condition and that you double check on these vital signs. You'll also want to check for DVT, pressure sores, and infection, since they will be in bed and they won't be moving around a lot. So as we've learned before, just before you start moving them, that you check for any of these. They'll also be very sensitive to light touch. So remember to use a firm grip when you're working with them, just so that you don't exacerbate their symptoms. And then they'll also have weak trunk control. So just remember to progress very slowly with transfers. Make sure that you are always with them and that you never let go, and you always have a hand on them. Gait belts, just because they're not going to be able to sit themselves up if you leave them unattended. And then another thing to keep in mind is that they may have weak bladder and bowel control. So to just be prepared that if they have to transfer to the bathroom, they might be incontinent. So here are our references.